Hey, Mr. Martin, question for you.
Sorry, I was muted. Go ahead.
You're good. You're good. Is this going to be recorded?
Yep. I just
Okay.
hit record, so you should have seen something probably pop up on your device that said enable. But yeah, it's recording right now. I just started it. So
Okay.
yep,
I
no
may lose
problem.
service, so that's why I'm asking.
Yeah, no, I totally get it. No worries.
I appreciate it, man. Thank you.
Okay. Yeah. All right, everybody, we're going to go ahead and get started. Welcome back. Please wait for the next available agent. Somebody was trying to type in and it isn't working. Let's see who that is. All right, there we go. All right, so welcome back, everybody. Hopefully everybody had a good break. Hope your Christmas and New Year's and everything went well. And you're all well on your way to weight loss. No, I'm just kidding. That's what we all do at the first of the year, right? All right. Well, I'm excited. I'm excited to get going today. So this is nuclear cardiology, NewtMed 4223. I'm excited about this class. I'm excited to get going on it. As I've told you guys before, my full-time job is working in a cardiac PET center, where nuclear cardiology is kind of my world. So it's exciting to get to talk about the stuff that I have my hands on every day, and do this section. So it's going to be good. Just a reminder, again, like those of you that are showing your faces, thank you. I appreciate it. I understand if some of you don't want to, and that's fine. I'm not too much of a stickler, but if you would, that'd be awesome. And I can see who I'm talking to. And then just keep muted unless you're, gonna talk or whatever. And just like always, you can interrupt me anytime. I'm totally cool with you interrupting me mid-sentence, so that I can have questions. I tend to not look at the messaging board too much, but I'll try to keep tabs on that. You guys are already being funny over there. Okay. Okay, so what I want to do is just start out with looking at our syllabus today and kind of go over Canvas and get everything squared away so that everybody knows what they're doing, what's expected of them, and then we'll get into our first lecture. So let me go over to my Canvas, I'll share screen, and we'll get going from there. All right, can you guys see my Canvas? Thumbs up, thank you, Bethany. All right, okay. All right, so hopefully some of you have had a chance to go on Canvas and kind of take a look through things. If you haven't, no, don't stress too bad. We'll get you up to date here and get you going. But I'm going to start off on the homepage here. I had kind of an introductory to the class so that you could get started before we had our first lecture. In this class, we're going to have a module that we're going to look at that's going to be the bulk of your assignments for the class. And then on here, I will also have lecture slides listed. And then also, this is where lecture videos will live once we have that. So after we're done today, and I'll get the video processed and get that posted on here as soon as possible. But this is kind of where some of those basic things will live. And it's very similar to what I did last class that you guys had with me when we did physics and instrumentation. Let's go to the syllabus next. So in this syllabus, we're going to be we'll look at the module here in a minute, and a module has a lot of information on it as well. And so the syllabus really just kind of has the basics of when we're having class and what we'll be discussing, and then it breaks out to grading. A reminder on here that I've said before, and some of you have experienced this already, but the best way to get a hold of me is not necessarily just to use my email, but rather to use Canvas messaging, because I have a Canvas app on my phone that will give me an alert. Now, that doesn't mean I'm always immediate, but sometimes I'm really good at responding, and so I try to do that. Sometimes I'm not as good. and I have to get to it when I can because I'm at work or whatever. So, but that's usually the better way to get a hold of me. So please message me on Canvas. And if you go right here is the inbox. If you go into inbox, that will allow you a place where you can send me a message. So that's the best way to get a hold of me. Required textbooks I've actually listed on the module, so we'll go over that in a minute. But the rest of this basically is just your schedule, what we'll be covering. So this is broke up into 4 different lectures. The modules match those same sections in the module, match the lectures. And so these are kind of our dates. What I want you to do is get through the module. Has section 1 and it has A and B, and then it has section 2, A and B. And so the way I broke up this is that section 1 is all together. So you'll do the whole entire module for section 1, both A and B, and then you'll have this time to take class. So the way I've designed it is we're lecturing today. That'll go along with section 1A in the module, and then we'll lecture on February 12th. That'll go in 1B, and then you'll be ready to take your test. Okay, so that interim period is complete the objectives, take the test. And then same thing with section 2, March 19th and April 9th, same idea. We're gonna have those 2 lectures that will cover A and B on section 2, and then you'll be ready to take your test. I've written out kind of the point value system that you have, but your objectives for section 1 and section 2 are going to be worth 25 points, and the test is going to be worth 50 points for the 2 tests that we do. So that's kind of your breakout. So pretty simple. Not a ton to this class. There is work involved in those modules, of course, but not a ton of testing. We're just going to do 2 basic tests and get you through that way. So that's the syllabus. Any question on that so far? Okay, I'm going to go over to the module. Okay. So the way that the modules broke off, well, first let's do textbooks. So the textbooks I have listed for this class, you're not going to have to buy anything new. I have kept the textbooks that you've already got. So the first one we have listed is the Waterstrom text. We'll stay in that. And then also the Medler text. You should have both of those from Physics and Instrumentation. And then also I have listed here the O'Malley text. That one should be the one that you're using with Brandon for his imaging classes. So you should already have all 3 of those, so nothing there to purchase. The only one that I put on here as a recommended text is the Norman Bullis book. So this is the review of nuclear medicine technology. And we're going to be going through this book next semester when we do our comprehensive review class. So if you can get it now, great. It's a good supplement for this class. The cardiology section in that book is really good. So I put it on there and I do reference it in the modules, but I don't want you to feel like you have to get that book to get what you need to out of this class. If you have those first books, it's fine. Don't stress. I understand books are expensive and you guys are probably all trying to work and do everything you're doing in school. So no stress, but if you can get that book now, it's a good supplement for this class. You definitely will need it for next semester. So however you want to work that. Okay, so the educational or the module is broken up into educational objectives in there's a section 1 and section 2, like I mentioned. And what I've done is I've given you're basically going to work through and create a document that answers the questions in these objectives. What I've done is I've given you the questions, and then there's a second section that points you where to go to get those questions. So I've gone in and referenced the textbooks and what chapters you should study and read to be able to have the information to answer the questions in the module. So for example, Part A, cardiovascular system. This is section 1, Part A. There's a Part A and Part B. Part A, define the terminology under key terms found at the beginning of chapter 17 in the Waterstrom text. So if you open up 17 in your Waterstrom text, there's a bunch of key terms at the beginning. Basically, I just want you to go through those and just do like definitions. Sort of grade school, junior high-ish, right? But they're all there's a lot of terms in nuclear cardiology that are different and good to know as you go through and learn and discuss. And so I want you to just become familiar with those terms. So in terms of what you're going to hand into me, just do simple definitions, like write the word, give me a quick little simple definition of what it is. I'm just looking super basic on that. These ones down here, describe the flow of blood through the heart and cardiac circulation. So this is just a verbal description of how the blood flows through the heart and the cardiac chambers. And we're going to go over that today in our slides, right? So you're basically just answering these questions. I don't want you to feel like this has to be a 25-page thing by the time you're done. You can do basic, just answer the basic question, keep it relatively simple. More than anything, make sure you understand what's being asked here. That's the biggest key, okay? And so you'll work through those. There's part A and part B for section 1. And then right after is the learning activities. This is where for section 1, it points you where you can go to get the information. So for example, here in part A for cardiovascular system, it says to study chapter 17 in Waterstrom, chapter 5 in Mettler, and then on O'Malley, I've given you some, 454 through 476, or 454 through 476. That should be a dash right there, sorry, not a comma. But you'll look at those pages. There's an EKG interpretation guide in Appendix F in that bolus book that I pointed to if you end up getting that book. And then, of course, my lecture slides will be available, right? So here's your learning section to then be able to go answer those questions. Same thing with part B. And then after that, it instructs you, now you're ready to take the exam. Same thing when you come down to the next section, section 2. It has A and B, all the questions you have to answer. And then again, the second part is going to point you to where do we get the information, okay? Hopefully that is understandable. Any questions on that, on how you're supposed to do that and what you're doing?
I have a question.
Oh yeah, go ahead.
So I started writing these out on a piece of paper. Is it okay if I just upload it that way, or do you want me to type them up?
Thank you for bringing that up, Bethany. I will tell you this, and I would prefer it to be typed. Because you've already done it, don't stress. I don't want you to redo it. I'm not about giving you extra work for nothing. There's 2 reasons why I like type. One, probably the biggest reason for me, and this a good example of this is test corrections. So like, I'll get some people's test corrections, and like, I literally have no idea. Like they won't list a number, and it will just be sentences like, and I don't know where it starts and where it ends. And trying to take time to decipher that is really hard, especially when it's handwritten. The second part is it's a college course, probably shouldn't do handwritten. Again, like I am not like that. I'm your least strict teacher you're going to have. I'm really easy. So Bethany, please don't redo what you've done. But maybe going forward, it would be good. It would be better to have it typed. It'd be easier for me to look at and grade and read and all that kind of stuff. So type would be better. Does that help?
Yes, thank you. One more question. Do you want us to cite any of our stuff that we find? Or
for which, are you talking about test corrections or are you talking about this?
the objectives?
No, you don't have to cite it. That's fine. I just want to learn the stuff. No, that's good. I mean, I'm assuming you're finding it in the books, and I'll try to read through, and if you're way off in left field, I'll try to help you out. But yeah, don't worry about citing. See, I tell you, it's like a college course on one hand, and then I don't make you cite. So, jeez, what a pushover. Don't take advantage of me, guys. All right. Any other questions? Did someone just go in the chat? Let's see, that popped up. Let me make sure. Okay, cool. Cool. All right. Okay, let's go. We got a couple more things on Canvas, and then we'll get talking and yakking on our lecture here. Okay, so there's your module. Let's go into assignment section. In the assignment section, it's going to have a place for you to turn in your module. So again, remember that for section 1, it has A and B. So when you click on here, you should be able to go in and you should be able to download just about any type of document in here. You also could just click this text button and you could literally just copy and paste from whatever document you have. If that doesn't work, but the upload button should work and that should get it to me. So that's the place to hand in your modules. And so you'll hand in 2 of those. Now under assignments, you can also get to exams and you can get to exam test corrections. Under quizzes, it will also have the exams listed. You can get to those either place, that's fine. I have made the exams available right prior to my lecture. I don't make them available before my lecture because I want to at least get everything out to you before you try to take the exam. So you people that are like doers and you want to get all done, I'm sorry. You can't get ahead of me that far. So but there's your tests. And then also here's the sections where you can submit test corrections. Again, I'm going to give you a reminder of this because I say it, I feel like I say it a lot, and then when I get them handed in, they're not always there. So just a reminder of these instructions right here. What you're to do on a test correction is write out the question you missed, the correct answer, and the reference material where you found it. So this is where you're going to reference. This is different than what Bethany was asking about the modules. And it doesn't have to be in like any format or anything. I just want you to tell me where you found it. Like if you found it in my lectures, just write lecture slides. If you found it in Waterstream, put Waterstream, maybe like a page number or something like that. So I'm just looking that you actually went and found it in a reference and corrected it. And then also, again, please, at the top of your document, write how many test corrections you're submitting so that when I'm going through, I know what I'm trying to look for versus trying to like decipher what's going on there. So just remember to do that, please. Okay, I think that's it, other than, obviously you know where the Zoom section is or you wouldn't be here, but I'll click on that anyway. I should have all the classes already listed on here and ready to go. So there's those for you. And then other than that, you know where to get your grades and things like that. So that's pretty much it. Any questions on how this class is going to function and what you're supposed to do? Okay, awesome. Let me get my slides pulled up then, and we'll get moving here. Okay, can you guys see my slides? Awesome. Lots of thumbs up. Great participation. Okay, so this is section 1A, that's going to go along with your module. Okay, so today we're going to be talking about cardiac chambers of the heart. And so we're going to spend a little bit of time on the anatomy first. And then we're going to talk about the conduction system of the heart. And then we're going to get into EKGs. Now, I will say from the outset, there's probably a lot of you thinking, why are we spending an entire lecture on EKG? And that's a valid question. You're not trying to be EKG techs, you're trying to be nuke med techs. And what I would say to that is that most exams that we do in nuclear cardiology involve EKG in one way or another. There is also EKG and understanding how it works, even involved in your imaging when it comes to perfusion studies. And there's multiple studies in which EKG is involved. Also, when we're doing a stress test, obviously we have to have EKG hooked up to the patient to monitor them during stress tests. So there's important things to learn here. Now, I know a lot of you in your facilities will not be doing the EKG. In most facilities, an EKG tech comes in and kind of runs that side of things. but it's still good for you to understand what you're looking at when you're looking at an EKG, and also some of the abnormalities that can be seen on an EKG that lead you to understand things about your patient that you need to know for emergent purposes and things like that. And so that's the reason EKG is included. On your boards, I think EKG will be a lighter part. There probably will be a couple of questions. They probably won't be too detailed. The other thing to understand is in this lecture, I'm also not trying to make you an EKG tech. In our facility that I work at, we've all been certified in EKG. We run our own EKGs. So I've been through the course to understand EKGs more detailed. I'm not going to give that to you. I wouldn't be able to do it in one class anyway. But I'm going to give you some of the basics and things that relate specifically to exams and procedures that you'll do. Okay. All right. So I want to talk about cardiac chambers and blood flow through the heart. Okay. So I'm just going to, and this is one of your first questions in the module asks you to trace blood flow through the chambers of the heart. So that's what I'm going to do right now. You guys have probably seen this before, but we'll talk about a couple of little caveats. But blood enters the heart through the superior vena cava and into the right atrium. When the right atrium contracts, it sends it through the tricuspid valve into the right ventricle. Okay. When the ventricles contract, it's going to then send it up through the pulmonary artery into the lungs. Through the lungs, it's going to return back through the pulmonary vein into the left atria. And then from there, it's going to come through the mitral valve into the left ventricle. Then when the ventricles contract again, that's going to send the blood flow through the aorta and into the rest of the body. Okay, so that's your basic tracing of blood flow through the cardiac chambers. Now, one thing I want you to look at here, I don't love this picture, and this is why I don't love the picture. In this picture, it makes it look like the right ventricle is a little larger than the left ventricle. It's actually the opposite that is true. The left ventricle is actually a little bit larger than the right ventricle. If you think about it, that left ventricle has to be responsible for getting a nice, good contraction because it has to send the blood flow throughout the rest of the body and back again. So it is the main pump of the heart. The other thing this doesn't show is that the actual myocardium, the heart muscle itself, is typically a little thicker and a little larger on that left ventricle. Just like if you did bicep curls and you only did them on the right all the time, your right arm's going to get a little bigger. It's got more to do, right? So same thing here. It's the left ventricle is a little bigger. Now, couple of things I want to talk about. One, and this is going to go throughout not only this lecture, but also as we start looking and doing perfusion studies and doing our stress tests. When we're in nuclear cardiology, what we're imaging and what we're looking at, and even when we look at EKG, what we're looking at is that left ventricle. We're very interested in the left ventricle. When we image, sometimes on an image you can see the right ventricle, but most of the time you can't. We're only looking at the left ventricle because, again, it's the largest chamber of the heart. It's the most important, and it's the one that puts blood flow throughout the body. And so when we have issues on that left ventricle, that's why they're emergent and urgent and possibly life-threatening. So just keep that in mind, that we're really focusing in everything we do, and every diagnostic thing we do is really looking at that left ventricle. There's a little bit of an exception when we talk about a MUGA scan, but not really. We still are mostly focused on that left, although you can see the right in a MUGA scan. So kind of keep that in mind. The other thing that I want to point out right away when we're looking at anatomy, and this is important as we start thinking about an EKG, because I want to translate this anatomy that we're going to learn into these waves and squiggly lines that you see on an EKG, is it's important to remember when you trace blood flow like this and like I just did, I almost made it like it was a train ride, right? Like we started in the right atrium, then we went to right ventricle, and we went up through the lungs, and then we came back to the atrium and ventricle. That's sort of misleading because although those flows are happening, what you have to remember is that when the right atrium contracts, the left atrium is also contracting. So there's things happening at the same time, right? The right ventricle contracts, and when those both ventricles contract, then when both atrium contract, both the ventricles are then filling. When the ventricles contract, blood's flowing through the body and up to the lungs, but also the atrium are filling, right? And when you think about a heartbeat, and you've listened to your heartbeat before, and people will say it's a classic lub-dub, right? That lub-dub, lub-dub, lub-dub. That's what's happening, is you're getting those two beats, the atrium and then the ventricles. So that's the lub, that's the dub. So lub-dub, lub-dub, lub-dub. That's what's happening. So when we think of blood flow, again, it's not like a train. it's multiple things happening at once. And when you translate to an EKG, those multiple things are what we're looking at when we look at the EKG, okay? All right, so that gives you kind of basic anatomy of chambers. The other thing I want to talk about is electrical conduction. And we're gonna get into the anatomy on the next slide here, but I want to show you this really quick. This is kind of cool, I found. So in the myocardium, in the heart muscle itself, we have what are called P cells. And those are the pacemaker cells in cardiac tissue. Cardiac tissue is really, really cool and different than any other tissue in your body because it actually has the ability to make a pace or a rhythm. You know, any part of my body, let's say I hooked up some electrical things to my bicep and I turned those on, it would contract my bicep, but my bicep isn't then going to just start beating, right? The heart's different because of these P cells. P cells are kind of primitive myocardial cells, and they are the site of pacemaker impulse. They can pace. I found this video online. It was pretty cool. They were actually doing some like stem cell stuff and found a way to start actually producing some of these P cells. So let's just watch this real quick. Kind of cool. Nothing you have to know or memorize, but kind of fun to see what they're doing.
We're trying to create living human.
Watch for this little thing to start beating when they give it electricity.
What's in this lab dish could revolutionize medical research. It's beating human heart tissue created from stem cells in a lab.
That's pretty cool.
I think this kind of research and lots of other, stem cell related research really has important potential to redefine how we treat disease in the future.
The heart tissue is made of stem cells that are turned into cardiac muscle cells. They attach to a collagen material similar to what's found in our skin and organs. That gives the tissue its structure.
So what we try to do is guide that process, guide that self-assembly to create a tissue that has the structure and organization that is representative of the tissues that we're interested in. So in this case, heart muscle.
A similar process has been used to create ears, noses, and blood vessels out of stem cells.
So we'll quit right there. We're going to watch the whole thing, but it's kind of cool. I think it's cool. I'm kind of a nerd. Hopefully you're a nerd too. That's why you're a nuke med. But but kind of cool what they could do. It'd be awesome in the future if instead of a pacemaker they could actually go in and get. All right. So anyway, that's P cells. Okay. So the cardiac tissue has primitive cells, and that's kind of a cool little sidetrack video there. Okay, so let's get into the actual anatomy of the conduction system, how it works. So I mentioned those P cells. The conduction system of the heart starts up in the right atrium. Or I won't say starts, I guess I will say start, but that's where it's located. So you have what's called the sinoatrial node, or a lot of people just say SA node. The SA node is basically just a concentration of those P cells. Now, the P cells are, like I told you, they're throughout cardiac tissue, but this concentration of them is kind of the person who, or not the person, the cells that control the beginning of the rhythm of the heart, okay? And so what happens is when the sinoatrial node will give off a signal, that signal contracts both the atria, right and left. The other thing that it does, the other responsibility is it sends a signal down to the AV node, which is the atrioventricular node, okay? So when that signal goes off, again, it contracts here, and then it sends a signal down to that AV node. When the AV node gets that signal, then it knows that it's its turn to contract. So it will send a signal first down what's called the bundle of His. The bundle of His then breaks off, and it turns into a left bundle and a right bundle branch, okay? And then those eventually, as they go down and out into smaller areas, into what we call the Purkinje fibers that go in multiple different directions. But this is how you get your cardiac contraction, right? So the SA node fires, that's the lub, sends off a signal to the AV node that then fires in rhythm for the dub of the ventricles, contracting those ventricles. And that's how you get that lub dub, lub dub, lub dub, okay? And so that's how that's contracting. So what I want to do now, and I've kind of wrote all that down here where you can kind of follow through where that happens. And this is another one of your questions on the module, is how to describe this process of what happens. So now what I want to do is I want to take that anatomy and then also this conduction idea and translate it to what do we see on an EKG? How does that look on an EKG, and what can that tell us on an EKG? Okay. So the first thing I want to look at is what we call the cardiac cycle. The cardiac cycle represents the contraction of the atrium, the ventricles, and then relaxation. So first we have what are called our waves. You'll notice that I have these waves listed from P to T, P, Q, R, S, T. The P wave happens first. I don't know why when they came up with this, why they didn't start on A since it's first, but we're starting on P. Random reason. I don't know why. So the P wave starts first. The P wave fires, and that P wave represents the contraction of the atrium. So that is the SA node doing its initial fire of the atrium. Okay, so P wave goes off, atrial fire. Like I mentioned before, that SA node and that firing also stimulates the AV node. When the AV node fires, you get what's called the QRS, okay, the Q, R, and S wave. That QRS complex, you'll notice they call it a QRS complex, represents the ventricular firing. It represents those ventricles firing. What you'll notice already is that you notice that the P wave is sort of small and the QRS is much larger. Why? Because the atrium are small, and so that wave they send out when they contract is much smaller than those ventricular waves, which again, remember I mentioned that left ventricle is the strongest one, so it's going to fire with a lot of strength, and that's what you're seeing represented here. And then the last one you have is the T wave, and the T wave represents repolarization. If you remember back to anatomy and physiology when you learned about sodium and potassium pumps, and that once the sodium and potassium have done their thing and fired off and contracted muscle, then you have this relaxation period where it rebounds. That's what the T wave is that's the relaxation or the repolarization of the cardiac muscle. So again, atrial contraction on P wave, QRS is the ventricular contraction, and the T wave is that repolarization or relaxation or complete relaxation, okay? The other thing I want you to notice on here is there's a couple of segments or intervals. We won't talk about every one of these, but a couple of them that we will reference is first this PR interval. So from the time the P fires to the time the R fires, that's a certain length of time. And we're going to talk about some conditions where that timing can become weird and lengthen weird, okay? And we'll talk about what that means and what it tells us. And then also the QRS complex itself has a finite timing of when that is actually happening. How long does it take for that contraction to happen? And then the other one that we'll talk about is this ST segment. So the end of the S wave to the beginning of the T wave, there's a slight pause there, and things can happen in that ST segment that again also tell us about what's happening with our patients. So we'll pay attention to that PR interval, the QRS complex, and the ST segment as well. Okay, so again, what I want you to understand when you look at an EKG, or at least on one of the things I want you to understand, when we talk about systolic and diastolic, you guys are used to that with a blood pressure, right? The systolic number represents the top number, and the diastolic's the bottom number. And what you're used to that representing is that the top number, systolic, means that the pressure when the pressure is put on the system when the heart's contracted, and diastolic means when it's relaxed, right? What are the pressures in the system of your body? Because you measure that on an arm, right? So it measures pressure that's being pushed through the vein, through the arteries of your system, and that's what it's measuring when we talk about systolic and diastolic. What those actually mean, what those terms mean, is systole is just contraction. That's all that means. Systole is contraction, diastole is relaxation. And the reason I bring that up and make it seem like, well, isn't that obvious from thinking about a blood pressure, is that when you're looking at a QRS complex, you're going to see both things, and you're going to see both things at different time. And what I mean by that, for example, when the P wave fires, the atrium are contracting. And what that means is that is atrial systole. But when the atrium are contracting, the ventricles are not contracting because they're filling with blood. So you have ventricular dystole, which is exactly the opposite of what you're thinking when you look at a blood pressure, right? So when the P wave's going, it's contracting, ventricles are relaxing. Whereas the QRS complex, you have ventricle systole, so the ventricles are contracting, and the atrium are at diastole, they're at relaxation. So I just want you to get that in your head to realize when we're looking at these waves, we're representing something that's actually physically happening in the heart. And then, of course, the T wave is that repolarization and then complete relaxation in between, okay? All right. So there's the anatomy. There is kind of what contraction means. Now I want to teach you how an EKG is set up, and then we'll start getting into looking at actual EKG waves and then talking about what they mean, okay? So when you're going to set up an EKG, on the outset, I'm going to tell you, I'm giving you like the perfect textbook way to do it. It's very caveated when it comes to a patient, you have to do the best you can. And you'll kind of see that as we talk here. But if we start out right, so you have your limb leads, which are your right arm, right leg, left leg. And then you have your V1 through V6 leads. Now this is a 12 lead EKG. You're going to notice if you count these, you've only count 10 stickers and wires. I will tell you in a minute on the next slide why it's a 12 lead EKG and what we mean by that. But for right now, just know that you have those limb leads, and then we're going to have V1 through V6. So I'm going to start talking about V1 through V6. So the location of V1 should be at the fourth intercostal space and to the right side of the sternum, just above the nipple line, okay? So what that means is that when I'm doing a patient, if I was doing a guy, it'd be pretty easy to palpitate that and find. A woman, you're not gonna do that. It's gonna cause you a lot of awkwardness. So you wouldn't do that. So these are kind of general guidelines. And even when I put an EKG on a guy, I kind of look for that nipple line and I go just above it. If you go just above that nipple line, you're gonna be about at that fourth intercostal space, okay? So that's where V1 will be located. Then V2 is the exact same location, just on the other side of the sternum. So you'll go V1, V2, just right on the other side of the sternum. I'm going to skip to V4 now, and the reason is that V4 is located in the fifth intercostal space, so one rib down, and it's going to be in the what we call the mid-clavicular line. So what I mean by that, if you go to your clavicle and you see the clavicle length here, if you go right in the middle of the clavicle and go straight down, that's where V4 should be located, okay, on that fifth intercostal space. And the reason I skipped is because if you can locate 1 and 2 and then do 4, all you have to do is draw a line between V2 and V4, and V3 just goes right in the middle of those two, okay? Then you have 5 and 6 are going to go out just straight laterally. V6 should be located on the lateral side of the body, just under the armpit. And so if you then go from 4 and you do 6, then you can just put V5 right in between, okay? And that should get you your V setup. Now, I will say with this, again, you're going to see techs do a variation of this that is a little different, and a lot of that is because things like breast tissue and patient habitus, so this can slightly alter. You won't see it perfectly like this every time. But this is kind of your textbook version. Slight alterations of this don't destroy your EKG. Obviously, if I took V1 and threw it way up in La La Land, then possibly. But for the most part, that configuration is going to get you pretty close. Now, the other caveat I'll say about here, you'll notice that right arm, right leg, left leg. If you went in for an EKG tech would likely put the right arm out on the arm, the left arm out on the arm, the right leg down on the leg by the ankle, and the left leg down on the leg by the ankle. That is kind of the textbook way an EKG tech would be taught to do that. However, in nuclear cardiology, we put people on a treadmill while they have EKG hooked up. And as you can imagine, you really probably don't want wires down by their feet while they're trying to run. You could get some pretty good problems, as you can imagine. So this is kind of the setup that we use in nuclear cardiology for an EKG setup. Now, one other caveat I will say here, is just a matter of experience and learning, is that when I set this up, this left leg and right leg, I don't put these this low. I try, if I can, to get these right up on the very tip of the ribs. And the reason I do that is because EKG conducts much better through bone than it does through adipose tissue. A lot of our patients in nuclear cardiology have some adipose tissue hanging out down there. That disrupts and makes the EKG signal much harder. So if you bring it up towards just on the lower part of the rib there, you're going to get a way better EKG signal on something like that, okay? Any questions on that? All right, so now that we kind of know how to set up the EKG, we know the anatomy, we know what's contracting, let's talk about how we understand what what the squiggly lines are doing. And there's one more piece that we need to put in place before we actually look at an EKG. And that is our leads. Now, remember a minute ago, I told you that it's a 12-lead EKG, but with only 10 leads. So this will start to help you understand. When you get, when you get a squiggly line on EKG, when that line is going positive, all the EKG is looking at is the beat of that heart. And when that heart wall comes closer to that lead, it gives a positive signal. It gives it a positive electrical signal. When the heart goes away from that lead, it gives that lead a negative signal. So what we then do is we're setting up our leads in such a way that they can watch the motion of the heart and give us positive or negative signal. That's what's actually occurring. Now, the other caveat to understand this really well, and we'll mention this again in some other lectures and look at some pictures, but the heart sits differently than the anatomic planes that you're used to. You're used to anterior being the front and posterior being the back, and right and left lateral and things like that. The heart, if you imagine it as a cup, it sits, put this down a little. So it sits in your heart. You have the apex, which is the bottom of the cup, and you have the base, which is the top of the cup where you drink out of, right? That was your heart. So the apex actually kind of sits a little bit forward, and then the whole heart is turned slightly to the left, okay? Slightly to the left. So the base is back angled, the apex is forward angled, and it's not, the front of the heart is not the front of you, it's turned slightly to the side, okay? So when we look at the heart, and you think of when I say this is the anterior portion of the heart, it's slightly actually to the left lateral is the anterior. So that can be a little bit confusing, and that'll translate later when we talk about perfusion and how we view perfusion imaging. But the heart just sits a little bit switched in the body. So what you have represented here, let's look at the V leads first. So the V leads are if you took like an axial plane in the body and you're looking at signals coming out in that axial plane. So like front to back, side to side, right? So V1 right here is coming out kind of out and to the left. V2 is kind of coming straight off the body. V3, V4, V5, V6. So that represents that motion. And here in a minute, I'll show you on an EKG, we can know by this which part of the heart you're looking at. So if something's happening, some weird rhythm is happening on V4 or V3, then I know I'm looking probably at the anterior part of the heart. If something's happening on V1 and V2, I know I'm probably looking more, again, remember, just left ventricle only, I'm looking at the septal or that medial side of the left ventricle, the septal side. If I've got something happening on V6, I know I'm clear out on the lateral wall of my heart. So we can see where things are happening based on those, that's what those are giving. The other way is that you've broken the plane into more of this sagittal type plane. That is sagittal, right? Come on, you X-ray people have to help me. I haven't thought of that in a while. Cutting through the body this way would be sagittal. Am I wrong? Coronal.
Sagittal, side to side, transverse
Yes.
axis, top and
So
bottom.
Okay, so it's coronal then. Thanks, you guys. It's been a while since I thought of that. So it's more like a coronal plane. So it's cut through this way, right? And so what you have represented, now remember, we only had those V leads, and then we have a right arm, left leg, right leg. You'll notice on here we have leads called AVL, 1, 2, AVF, 3, and AVR. The way that they get those leads or those directions is a combination of the right arm, right leg, and left leg. So for example, AVL, it looks at left arm mostly and references the left leg and then knows that AVL direction. Number 1 is almost a perfect mix of left arm and left leg lead. 2, mostly left leg, some of left arm. So it uses 2 signals to get a direction of where that's at, okay? So AVF is kind of just straight inferior, so it's going to use right and left. 3 is going to use mostly right leg, and AVR is going to use mostly right arm, okay? So it's getting a direction of the body. So in this sense, we then have the direction of the heart beating out this way, and then also through this way. So you kind of get multi-directions of that heartbeat, okay? And so that's how we're gonna get our squiggly lines on our EKG, is it's directional of heart motion, okay? All right. Okay, so now I'm going to show you an EKG, and before we start talking about the waves, this is your anatomical correspondence, okay? So what I mean by that is if you look at, so on an EKG, you have lead 1, lead 2, lead 3, AVR, AVL, AVF, and then you have V1, V2, V3, V4, V5, V6, okay? So remember I said V1 and V2 were kind of more towards the anterior of your body, but if the heart's turned, then we're looking at septal. So that's septal leads, V1 and V2. V3 and V4 are going to be your anterior leads. V3 and V4 come out slightly angled this way, but that's where the front of the heart is. It's out to that left slightly. So you got anterior leads that you're looking at. And then your lateral leads are V5 and V6, right? All the way out to the side, you're looking at what's happening laterally. And then remember, I mentioned the combination. So V1 and AVL are going to be your lateral leads. If I go back, that's why we got 1 and AVL, lead 1 and AVL. You can see where that's lateral. Inferior leads, you have 2, 3, and AVF. If I go back, 2, 3, and AVF, you can see that's inferior. And then you'll notice that AVR isn't really anatomically corresponded. There's a few things that EKG text will use AVR for that I'm not going to teach you that you don't need to worry about. But you'll notice AVR is kind of up here and to the right. And if you think about the heart all being kind of concentrated on the left, and especially the left ventricle being concentrated on the left, there's not much signal that you get coming up AVR. You get a little bit, but most of what we're going to use to diagnose is coming out this way as it beats, right? It doesn't really beat up in that way. It beats kind of out to the left. So that's your anatomical correspondence, okay? So now let's look at what we're looking at on an EKG so we can kind of understand as we start to look at it. So what you have here, you've probably seen an EKG before. You notice that it has a grid pattern on the back of it, okay? If we're looking at the y-axis on that grid pattern, that represents voltage. Remember a minute ago I said when your heart beats, the strength of that gives off a certain voltage. And so that's in millivolts. So each of these boxes represents 0.1 millivolts. So that's how strong the contraction is. And then the x-axis is time. And each of these little boxes is 0.04 seconds. Or if you combine, you'll notice that there's a dark line around 5 of the box lengths, and it's 0.2 seconds, okay? So that's representing time. We're representing time and strength, okay? The other thing I want you to know here, and we're going to talk more about this in our next lecture when we talk about gated blood pool studies and when we talk about gating and what that is. But for right now, I just want you to understand what's called the R to R. There's an R to R interval. So where the R wave is to where the next R wave is, we call that an interval. And if you have a heart that's beating in a perfect good rhythm, that R to R interval should be the same. You should be able to get out that little instrument called a caliper that has the 2 ends on it. And you should be able to put one point of the caliper on one R wave and then one on the next R wave, and then move it to the next set of R waves, and it should stay exactly the same for a normal rhythm, right? So we pay attention to that R wave. The other thing that happens is your EKG machines, when they spit you out a heart rate, that's what they're looking at is the length of that R to R interval, okay? So it's looking for those R waves. And when we talk about gating next time, we'll talk about how your gamma camera and your PET camera also look for the R waves to be able to do the gating processes that we'll do in our images. All right, let's actually look at an EKG now. Whoa, lots of buildup. So this is a normal, what we call normal sinus rhythm EKG. You'll hear that referenced. I want you to look. So it has our normal breakup of 1, 2, 3, AVR, AVL, AVF, and then 1 through 6. And then a lot of EKG machines will give you, it'll pick like a rhythm and just kind of give you a solid strip of one lead. And that's what I'm going to look at for this purpose because it's like kind of the most classic. So this is actually lead 2, just repeated through in a straight line. And what you'll notice on here is you've got a nice P wave. You have your QRS complex, it's nice and big. And then you have your T wave, then you have a little rest period, and then it repeats. And again, if we took those calipers and we put one here and measured that, every one of these would measure exactly the same. What that means is this is sinus rhythm. The reason we call it sinus is it's being controlled by that sinoatrial node. That's what the sinus stands for. So that sinoatrial node is firing, firing its atrium, the P waves are going off, that signal is going down to the AV node, that's perfectly firing the ventricles, and then it all resets. This is exactly how you want your heart to beat, normal heartbeat, okay? We're going to look at a couple different abnormalities. The first one is atrial fibrillation. Okay, so what's actually happening in atrial fibrillation is this is usually a failure of the SA node. So the SA node is not firing like it should. And remember that I told you in cardiac tissue, those P cells are located all throughout the tissue. And this is kind of a cool redundancy in our heart that keeps us alive, is that if the SA node fails and it stops working, your heart tissue will immediately start to find another P cell to run the show, okay? So what's happening in atrial fibrillation is that SA node is failing in some respect or way, and so other nodes are freaking out, and the atrium is kind of trying to fire a bunch of different things. So I've got a little video here. I don't know if you can see it very well. It's kind of a little GIF. But what it's showing you here is that SA node over here on the right is not firing. So then a bunch of these other nodes are kind of trying to take over. And what you usually see is this random firing of P waves. Often on the EKG, if you look right here, if you come along here, you know, you're like, okay, I think I see a P wave there, and there's a QRS, and that looks like a T. And then I'm not sure there's a P wave on that one, but there's a QRS that went off. And we get down here, and it almost looks like there's like 3 P waves in a row. I don't see a T wave. So what you're going to get on here is you're going to get a lot of randomness going on when you're looking for Ps. The other thing that will happen in here is that every once in a while, that atrial trying to conduct is going to hit the AV node, and you're going to get a rhythm fired or a QRS fired, but it's going to be irregular. So when we look at atrial fibrillation, we talk about it being irregularly irregular, because what the QRS looks like can be affected by not a great signal, but also it's going to randomly be hitting it, which is why if I took a caliber on my R to R waves here and I measured, you'll notice that these are different. Like these from here to here is not the same as from here to here or from here to here. Because again, you're getting ventricular firing at this random way because the atria is just kind of freaking out. So that's atrial fibrillation. You can stress a patient with atrial fibrillation as long as that atrial fibrillation is not causing the QRS complex to not fire, and you're getting like barely any QRSs, right? But then you're going to notice your patient's going to be feeling like crap and passing out. Okay. All right. Sorry, guys. It's wild. Okay, so I'm trying to remember exactly where we were. We were talking about atrial fibrillation, right? And you get this atrium that's kind of going crazy. Some of the patient presentation for this can be the patient may feel some heart palpitations, or they may feel their rhythm a little bit weird. Not everybody does, but some do. You could have shortness of breath, especially if you're getting it where the QRS complex isn't conducting very well, so you're getting not very many conductions there. That could be a problem. Could feel weak again because of low circulating blood flow. Some patients don't feel anything. They still get a good rate going, and they're okay. One of the things that can happen with atrial fibrillation is risk of stroke. What happens is in the atrium, and not everybody has these, but in the atrium, you can, especially in the right side, you can have what's called a right atrial appendage. And it's part of the atrium that didn't close off at birth. There can be a teeny little pouch in the atrium. And what can happen is blood can get in that pouch, and because it doesn't contract out very well, it can kind of get stuck in there and coagulate. And then in atrial fibrillation, when you've got the atrium freaking out, sometimes that can get dislodged and send a clot through the system. So that's one of the things that increases stroke risk with atrial fibrillation. I mentioned a minute ago, you can do a stress test when someone has AFib, but again, you're probably going to be under the direction of a PA or something like that for that kind of thing. But you can do it. Any questions on AFib? Okay. All right, let's go to the next one. So the next one I want you to know is ventricular fibrillation. This one is more serious. So this is a very similar thing that's happening here. In these scenarios, you probably have good atrial contraction. So the SA node is firing, but what's happening is the AV node is not seeing that fire. It's not functioning. So when it gets a signal, it does nothing. What happens in response, again, is the P cells that are within the ventricles start to try to make up for that and try to do something. I'll have another little GIF over here. You can kind of see the same thing. So it's not getting a signal and they're kind of trying to fire. Usually in this scenario, you're not going to get a good contraction. And because of that, that's why you see the patient presentation here. You're going to have a loss of consciousness. You could have chest pain, dizziness, shortness of breath. This actually is an emergency. This would be worth calling a code. And if you look over at your EKG, what you'll notice is it looks like it's just, this one actually looks like your kid took a pen and just colored on paper, right? It's a squiggly line. And it's because the ventricle is just trying as hard as it can. It's popping off a bunch of contractions, none of which are doing very much good to actually get blood flow through the body. So ventricular fibrillation, if your patient goes into this, obviously we don't stress this patient and it is an emergency. So you should be calling a code. And again, you're going to know that because your patient's going to be presenting in areas like this, like chest pain, dizziness, loss of consciousness. It's going to be an emergent situation. Okay. Any questions on ventricular fibrillation? Okay. So now what I want you to understand, and this can be confusing at first. When I was first learning these, I didn't separate them. Did someone have a comment? I thought I heard somebody. No? Okay. What we've talked about right now is just a conduction problem happening in the atrium and a conduction problem happening separately in the ventricles, those two conduction problems. What we're going to talk about now is what we call AV block. And so let me go back really quick to this anatomy picture right here. AV block is going to be a communication disruption between the SA node and the AV node, okay? These blocks are going to talk about something right here is occurring that we're not getting good communication between those two. That's what we're going to talk about next. And these are the blocks. They call them AV blocks. Okay, so the first, and these are separated by degrees. So AV block, if you have a first degree AV block, what you're going to see happening, if you look at this EKG strip, you're probably going to notice you have a P wave, and you have a QRS, and you have a T. You have another P wave, QRS, T. But what I want you to notice is there's quite a bit of length right here between where the P wave goes off and then where the atria finally fires. So this is like a delay. So what's happening here is the SA node is firing, but for whatever reason, the AV node is like out to lunch and he's not paying attention. And it's like you get called on in class and you were like sleeping and it's like, oh, shoot, I woke up. It's like, oh, okay, I'll fire. And you're in fires, right? So you get this delay. So there's a delay. So first degree AV block is just simply a delay in that PR interval that we talked about. That PR interval is lengthened. And the qualification for this is that the PR interval is more than 5 boxes in length. That would be greater than 0.2 seconds or 5 of those small boxes. Now you'll notice that 5 of those small boxes is 1 large box, so you could look at it that way too. 1 large box or 5 of those small boxes is what qualifies for actual first degree block. Most of the time these are asymptomatic at rest. However, you can have some reduced exercise tolerance. And if you think about it, when you exercise, your heart rate has to increase to keep up with oxygen and blood flow throughout your body. And so the reason it can reduce exercise tolerance is that as those waves get closer together, what can end up happening, you'll notice how close the T wave and the P wave are here, is that you can get to where you don't get complete relaxation because the P wave is coming over into the T wave. And so if you don't get complete relaxation, then you also don't get complete filling. And so that's why at exercise, when the rate is quicker, it can make the patient feel like, man, I just don't quite have enough there. And that can be because of that first degree AV block. Okay, we can stress these patients and we can put them on the treadmill, but these are just things to kind of know. I will tell you this too. This is the only block you can put on a treadmill or stress. The rest of them are no-nos, okay? So second degree is divided into 2 different types, type 1 and type 2. I'm going to tell you about type 2 first. It's also called MOBITs. And so what I want you to do again is we're going to start by looking at the P wave. We start at the P wave. You'll notice there's not a lot of length here. So this looks pretty normal. So we got a P, we got a QRS, and then we have a T. So far looking at that first QRS complex, it's like, sweet, looks great. But then you get to the next one. And what I want you to notice here is that it's also looking good. We're like, okay, we're good. Next one's pretty good. And then next one, we have a P, and we just have a complete drop. Okay. So what happens in Mobitz is that every once in a while, and usually it's in like a rhythmic pattern, you'll get like 3 beats and then a drop, or 2 beats and then a drop, or whatever. But essentially Mobitz, AV block of the second degree Mobitz type 2, you're just going to get this dropped QRS complex out of nowhere. And so you notice you have this big space where nothing's happening with the heart. It drops, nothing else happens, and it goes right back into the normal rhythm. Okay. So what you'll notice here as you're looking at this, what I want you to think, and with a lot of these blocks, the first question you ask yourself when you think you might have a block is you say, are there more P's than there are QRSs? And that's an answer of yes right here, right? Because you got 1, 2, 3, 4, 5 P's, but you only have 4 QRSs. So are there more P waves than there are QRSs? The next thing is the P to R interval, you'll notice, is fixed. In other words, when a P wave goes off, there's not different lengths between these two. It fires and then it's normal. It's a normal beat. It's a normal fixed pattern, but it just drops every once in a while. So with this one, you can have fatigue, you can have shortness of breath, you can have really slow heart rhythms, because remember I told you that the heart rate is calculated from R to R waves. So the computer's going to look at these two and be like, oh, well, if I only have this to look at, I'm going to calculate this out as a certain heart rate. But now I have this huge break. That's going to bring down what your heart rate looks like when it's calculated out. So you're going to have bradycardia. You can have fainting, depending on how many of these are happening and how long the space is. And you can have cardiac arrest with this. That's super rare, but it is a possibility because, again, you're dropping a beat and having a long pause, and then it's coming back in again, okay? We don't exercise or stress this patient. The next one, which is the Mobitz type, the second degree type 1, is what we call Wenckebach. And we're going to do the same thing. If you start on this P wave, you'll notice you got a P wave, you got a nice QRS, nice T. Now you got this next P wave, but what I want you to notice is look at this. This length is a little longer than this one. Then you get a QRS, then you get a T, now you get another P wave, and this one's even longer. Then you get another one, and now this one's out here in La La Land, and now you notice you had a drop. So the little rhyme they use for this is it's longer, longer, longer drop, then you have a Wenckebach. Okay, longer, longer, longer drop, then you have a Wenckebach. So that's what you're going to see. You're going to see that lengthen, 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 and then it's just gone. This one can be asymptomatic. This one can also cause problems like fainting and also the bradycardia. Again, more P waves than there are QRSs, right? Because we end up with a dropped one. This one, your PR interval is not fixed. In other words, the length between the start of the P and the start of the Q it gets bigger and bigger, so they're not fixed. So that's another thing you can tell. Like this is getting bigger and bigger. They're different. They're not fixed. And then again, that longer, longer, longer drop idea. So that's a second degree Mobitz Wenckebach. Third degree AV block, and again, we don't exercise that patient either. AV block third degree. So this is where there's basically just complete disassociation between the P wave and the QRS. So you'll notice right here, you've got this P wave right here. There's no QRS whatsoever. Then you suddenly have a QRS. Then you have, it's like, is this a T or a P? I'm going to tell you it's a P. Then you have the T wave of this QRS. Then you have another P wave. Then nothing. Then a random QRS. Now you have right here, this is a P wave inside the T wave. And then nothing, and then another fairly normal one. So what's happening here is if you took that caliper instrument you could measure with, and you measured from P wave to P wave, the P wave actually is equal. It's marching out. So from here to this P wave is the same as from here to this P wave is the same as here to this P wave and to this P wave. You'll also notice the QRSs you could do the same thing with. So what's happening here is they have both completely made up their own rhythm, and they're not talking to each other whatsoever. This is like husband and wife got in a fight. They're ticked off at each other, and they're like, I'm not talking to you the rest of the night. And so they do their own thing, right? That's what's happening right here, is you get complete disassociation. So you can get some shortness of breath because of the weird, what you can imagine from here is if the heart needs to be timed where the atria push the blood flow into the ventricles, and then the ventricles then push it to the rest of the body. And if that timing isn't right, then you don't get very good feeling, right? It can be off. In this scenario, as you notice, this P wave is almost right in the middle of the QRS, which means that the atrium and the ventricle are like contracting together. And so you probably didn't get much blood flow going anywhere from that, one way or another. It just kind of squirted in all directions, right? And so that's why you can still get some of this idea of like fatigue, chest pain, fainting, and really slow heart rhythms, because there's just kind of essentially two separate things happening, okay? Again, more P waves than QRSs. We don't have a fixed interval, and everything looks just that they're totally disassociated. Okay, so that's third degree. Again, we don't stress that. Okay, so those were the blocks between the SA node and the AV node. Okay, the only one you can do a treadmill or a Lexiscan on is first degree. The rest of them, you can't do it. Now, so remember, that was the communication pattern right here between the SA node and the AV node. I'm going to show you two more things. We call them bundle branch blocks. And this is going to be where the AV node fires, but these branches have some communication issues. So they're not getting a good signal sent down the line, or a delayed signal is really what it is. That's what we're going to look at next, okay? And we're getting close to being done. Sorry, this has gone on long because of our breaks. Okay, so, okay, bundle branch. If you go into EKG, they're going to teach you about what's called morphology, which just means what does the wave look like? Does it look like what we normally expect, or does it look like some other weird wave pattern? For a bundle branch block, you typically look at the anterior leads, so like V1, V2, V3, and what you'll notice on a right bundle branch block is you usually have, they call it rabbit ears. So you look at the QRS and you have these two, it's two different R waves. What was that? Faith, did you have a question?
No, sorry, my computer just randomly unmuted. Sorry.
No worries, thanks. So you'll have this little bunny ear pattern, and that's a right bundle. And then on a left bundle, what you'll have is, instead of the QRS immediately going up, it's going to immediately come down. You're going to have this downward pattern. Now this picture, I probably need to find a better picture because it includes the lateral leads, which we don't typically look at for blocks. And you'll notice that they're different. But the classic is, you look at the anterior leads. If you right bundle, you have this bunny ear pattern, and left bundle is going to be this inverted QRS. Now, the other thing that really qualifies it is not so much the morphology, and this is the one I want you to put in your head, because you won't be asked a morphology type question. What you have is, you have a lengthened QRS time. That QRS interval from the time the Q starts to the time the S finishes, it's lengthened. So that's what I wrote down here. If you have a QRS duration that's larger than 3 boxes, or 0.12 seconds, that qualifies for a block. And if you think about it, what's happening is the AV node fires. And again, it's like being asleep in class. AV node fires and asks the bundle branches a question, and they suddenly wake up like, oh, yeah, sorry, we'll fire. And so you get this lengthened period of QRS. The QRS doesn't fire quickly and sharply like it should. It kind of is slow and takes a second. So that's what you're looking at here. You'll notice in any of the other EKGs we looked at, the QRS complex was a lot shorter, less than 3 of those boxes. So when we start getting wider than 3 of those boxes, that's when we have a bundle branch block, okay? And that's what you're going to see on an EKG. Now, why do I bring this up for you guys specifically is that we're going to look at this next one. When you do a treadmill, and we'll talk about this in more detail when we do our stress test section, but you cannot run a left bundle branch block on a treadmill, okay? So you need to be able to know what one looks like, but you can't run one, and there's 2 reasons why we don't do that, and that's what I'm going to tell you right now. What I want you to notice here, and maybe I should go real quick before I show you this one. I'm going to show you this slide right here. Remember I mentioned that you could also look at this ST segment for some information, okay? When we have ischemia, what happens, and what ischemia means, is that you've got reduced blood flow somewhere in the heart, okay? So blood flow has now been reduced, and we'll go over ischemia and infarct more when we talk about perfusion. But in ischemia, what you see is, you see this ST segment depression, okay? It comes down. You can also have infarct. Infarct means the tissue is missing the blood flow. Infarct can also mean a dead tissue. So you'll hear in the ER, they'll say something like STEMI. We have a STEMI. What that stands for is ST elevation myocardial infarct. So that patient, this patient is having a heart attack. Something has been blocked and they have an area that's infarcted, which means completely blocked off of blood flow. Okay. So when we see ST elevation, we have an infarct, we have an emergent situation. When we see ST depression, that means there's reduction in blood flow and the patient is losing blood flow in some area or being reduced. Okay. So the reason why I pulled that up is because when we look at a left bundle, so this image right here is a left bundle branch block. You can see that the QRS is really wide, but you also notice that you get this really high ST segment. This right here is a heart attack. You'll notice the QRS is not as wide, but it looks very similar. You see this ST elevation. That's that myocardial infarct. You'll notice it here as well. Some people call this the tombstone, right? Because it represents like they're an emergent death, life or death situation, okay? So ST elevation is what represents that. So the first thing you're going to notice is that a left bundle looks a heck of a lot like ST elevation, looks like an MI, okay? The way to distinguish that, of course, is the width of the QRS. But again, they look very similar. Now, here's the problem. You put someone on a treadmill who's got a left bundle, and they start increasing their heart rate, that it gets very, very difficult in a situation where treadmill's moving and heart rate's increasing, and that's happening really quick, to distinguish the difference between an acute myocardial infarct, they're starting to have a heart attack, and a left bundle branch block. On a treadmill, it's virtually impossible to be able to see those two different things. So that's one of the reasons we don't run them on a treadmill. The other reason is that, as you can imagine, and I'll go back to our anatomy picture real quick. If you are seeing, again, remember what's happening in the left bundle is these bundle branches are firing slow. So you're getting this slow contraction. If you're exercising, heart rate starts to get more and more. So you're needing your heart to be fast to keep up, and it has a slow contraction. And what that means is that the actual myocardium, in other words, the blood flow coming through the coronary arteries, has a very hard time filling up in the septum. Because of that contraction happening so quickly and happening erratically and happening slow, you don't get proper filling in the septum. And what that means is that when I pull up my perfusion study and I look at all my slices, you're going to have a false septal defect. It's going to appear as though there is a blockage to the septal side of the heart. But really it's not. It's just a left bundle branch block that's preventing that blood flow from getting back in because of the way that's contracting. Okay, and the reason that that's important is obviously you just made your test false, right? So you get a septal defect, and now you guys end up sending your patient to the cath lab for a cath. They go in, they put the dye through the coronary arteries, and they're like, "What? There's nothing here. There's no problem," and we've just given a false test. So those are the reasons that we don't run someone to left bundle branch. Now you can give Lexiscan. You can do a chemical stress on a person with left bundle, and that's because when you give a chemical version of a left bundle, you do get some heart rate increase, but typically you're going to increase it by maybe 20, 30 beats. Whereas when you're exercising, you have to get up to about 90% of their exercise capacity. So you're gonna end up with something way, way, way faster. So there's a little difference there. So we can chemically do a left bundle. We can't put a left bundle on the treadmill. No, that's the reason why. And then we've already talked about that. That's it. You made it. Questions? Yes, Jesse, we stress left bundle with Lexi. Yep, absolutely. You can do it. You can do a Lexi, just can't treadmill. Nobody else test. I just did a stress test yesterday on someone with AFib. Yep, and stress testing on AFib, like I said, you can stress test an AFib. because again, you can get good contraction with AFib. It's VFib that we don't stress. And honestly, if your patient comes in and they're in VFib, it's not like they're going to walk in and you're going to be like, okay, we're going to stress test on you. They're going to be feeling emergent. So you're going to know right away anyways. So, okay. Anything else? Okay.
These all the basic ones that we need to know, or are there any other ones that we probably should know for our registry?
These are the basics. What I gave you is the basics. I'm actually probably just a teeny bit deeper than your registry, simply because I think it's good to know when you're around this stuff. You need to have a second set of eyes. But the ones you need to know for registry for sure is you need to know that you can't run a left bundle, because that directly affects our test. Let me go back over here and just, you could get this elevation question, elevation or depression on ST. Because again, that's emergent and need to know kind of situation. Like I said, in a lot of your scenarios, you're going to have an EKG tech there, but some you're not. And so I could see this question being on the boards because it's so important and emergent. So yeah, bundle branch block for sure, knowing that when you can stress that. And then I would say with these other blocks, for board scenarios, they're not going to ask you specifics about how these waves work and what happens. But what I do think you should know for boards is that you can't stress anything above a first degree AV block. Okay. I do have some questions on my test about these rhythms. Kind of knowing a few little things, nothing crazy, but I do have questions on mine. But you probably, they probably won't get that detail on a board. I would know what AFib and VFib are for sure. And when the fact that you can stress an AFib, but you definitely can't stress a VFib. And I would know the patient presentations of when they have AFib and VFib and what the patient might be looking like and experiencing. And then I would know a normal sinus rhythm, what that looks like knowing the waveforms and stuff, I think could be a question on your board. Like knowing that, the P waves means that the atrium's contracting and the QRS complex means that your ventricles are contracting, just kind of the basics there. Most of what I give you here, I think is possibility, but again, like I said, I go a little detailed on those rhythms to explain what they are, but so hopefully that helps. Anything else? You're going to need to know your R to R wave, because on our next lecture, we're going to talk about our gated studies. And so that's important, understanding the R to R wave, what that means. And again, we'll give you more detail as we go along. So yeah, I think that's... Any other questions? Okay, I'm going to turn off the slides. And so yeah, in between now and then, get those sections studied in the book, work on your module. Again, you don't need to hand anything in right away. We'll do the next lecture. Just study up, and we'll see you next time. And Kim, if you're still here, thanks. And I'll try to figure out what the heck's wrong with my Zoom.